Hello everyone, welcome to our module on cholinergic antagonist. Very simple topic, very short topic, and I think this video will be enough for writing your exams or appearing for a viva. So what will we study in this video? First one is the classification of cholinergic antagonists. Second is the mechanism of action, how they act, drugs and their actions on different parts of the body, in what condition those drugs are used, then anticholinergic toxicity, and finally contraindications, in which cases we should not use these drugs. And if you read once from the textbook after listening to this lecture, I think you are good to go in this topic. Coming to the classification, anticholinergic drugs are divided into three classes. First one is natural alkaloids, second one is semi-synthetic compounds, and third is synthetic compounds. Natural alkaloids are atropine and hyoscine. Hyoscine is also called as scopolamine. Semi-synthetic compounds are homatropine, ipratropium bromide, tiotropium bromide, atropine methonitrate, and hyoscine butyl bromide. And synthetic compounds are oxybutynine, cyclopentolate, tropicamide, darifenazine, solifenazine, and dicyclomine. Guys, trust me, you don't need to forcefully memorize these drug names because most of these drugs come in further chapters, and while covering those chapters you will get familiar with these drugs, so automatically they will get fitted in your brain. And some of these drugs we rarely use, so we don't need to memorize those names. And we will frequently hear drugs like atropine, hyoscine, ipratropium bromide, tiotropium bromide, and oxybutynine, cyclopentolate, and tropicamide. So automatically they will get fitted inside your brains. Coming to actions of these drugs have exactly opposite action to cholinergic agonists. If you haven't watched our video on cholinergic agonists, I suggest watch it. I have explained receptors and autonomic nervous system and cholinergic agonist drugs and their actions in a nice way. This video will be helpful for you. Coming to action on eye, cholinergic agonists cause miosis. So cholinergic antagonists will cause mydriasis. Mydriasis means increase in the diameter of pupil. Cholinergic agonists cause accommodation for near vision. So cholinergic antagonists will cause accommodation for far vision. Coming to action on sweat glands and salivary glands, cholinergic agonists cause salivation and lacrimation, but cholinergic antagonists will cause dry eyes and dry mouth. Then next, action on GIT. Cholinergic agonists are secretomotor to GIT, which means they will increase the peristalsis and GI gland secretion. In cholinergic antagonist case, they are opposite. They will relax the GIT muscles, they will decrease peristalsis, and they will relax the sphincters. Next, action on smooth muscles. Anticholinergics don't have any effect on blood vessels, so they don't cause vasodilation or vasoconstriction. And coming to bronchial smooth muscle, anticholinergics dilate the bronchus by relaxing the smooth muscles in its walls. And coming to urinary bladder, anticholinergics decrease the tone of urinary bladder, which means it will help in accommodating more urine and it will close the internal urinary sphincter. How do these cholinergic antagonists work? Cholinergic antagonists bind to the muscarinic receptors without activating them and preventing the binding of cholinergics. As we know that there is a muscarinic receptor, serpentine receptor present on the cell membrane where acetylcholine binds and acts. What these cholinergic antagonists do is they bind to this site and inhibit acetylcholine from binding to the receptor. These cholinergic antagonists, when they bind to the receptor, they don't activate the receptor itself. And point worth of noting is that cholinergic antagonists do not bind to nicotinic receptors. Nicotinic receptors are blocked by the skeletal muscle relaxants, which we will talk about in other modules. Coming to uses of these drugs, first use is mydriatics. These drugs are used to increase the pupillary diameter when doing fundoscopy eye examination. And second use is antispasmodic and anti-secretory. Some patients get GI spasms which will cause painful contraction of their GIT. So cholinergic antagonists are used to reduce those spasms. And antisecretory, these drugs are used during acidity to decrease the acid secretions. Usually atropine is used in these conditions. And for mydriatrics, atropine was previously used, but nowadays shorter acting drugs are used like tropicamide. Third use is overactive bladder. Some people void urine without their voluntary control, or some urine is dripping from their bladder. To decrease the tone of bladder and decrease the urine output, anticholinergics are used. Fourth one is very important use, bronchial asthma. In this, ipratropium bromide, tiotropium bromide are used. They cause the relaxation of bronchial smooth muscles and help in bronchodilation, which will allow more air to flow in. And in case of overactive bladder, oxybutynine is used, which is M3 receptor selective. M3 receptors are present in the detrusor muscle of the urinary bladder. Nowadays, dicyclomine is used because of less side effects of dicyclomine. Fifth one is bradycardia due to high vagal tone. Some patients of anxiety have high vagal tone, which means their parasympathetic activity is high, which causes increase in heart rate. Anticholinergics are used, mainly atropine is used to cause bradycardia. Sixth one is Parkinson's disease. In Parkinson's disease, there is an imbalance between acetylcholine and dopamine in the brain. Acetylcholine levels go up and dopamine level rises. Anticholinergics are used to counter these effects of increased acetylcholine. Next is anticholinergic poisoning. It is usually rare but happens commonly with the use of atropine, or sometimes small kids they ingest the seeds of Atropa belladonna plant from which atropine is extracted. So in them anticholinergic poisoning occurs. Clinical features are opposite to cholinergic poisoning. In last video we saw what are the features of cholinergic poisoning. If you haven't watched that video, please go and watch it. So clinical features are dry eyes, pupil dilation, dry eyes because of blockade the lacrimal glands, pupillar dilation as we talked about, mydriatics, blurred near vision. As you know, there is accommodation for far vision, so near vision is lost. Dry, flushed and hot skin. Dry means there are no sweat glands secretions. Hot skin, fever, palpitations, dry mouth and difficulty in swallowing. Excitement, ataxia and hallucinations are central nervous system effects. So what is the treatment for anticholinergic poisoning? First, gastric lavage with tannic acid should be done. Then drug of choice is physostigmine. It is a cholinergic agonist drug which also acts in the CNS. So in anticholinergic poisoning we can use this drug. Third one is cold sponging, maintenance of blood volume and respiration. Cold sponging to decrease the temperature of the body, maintenance of blood volume because there is severe bradycardia, hypotension is there, and respiration. Coming to contraindications, in which conditions we should not use cholinergic antagonists. First one is angle closure glaucoma. If we use these drugs in angle closure glaucoma, there will be severe rise in intraocular tension and it will further precipitate the attack of glaucoma. Second thing is elderly males with prostate hypertrophy. What happens in these patients is the enlarged prostate will cause urinary retention. It will compress the urethra and not allow the passage of urine. So if we give these drugs in them, then there will be further urinary retention. And in low BP, as we know, these drugs cause bradycardia and hypotension, so they are contraindicated in low BP. So that finishes this chapter. Thank you for watching, and if you want any topics, please comment. I will try to make these topics as soon as possible.